Okay, so this morning we're going to finish this chapter, and we've just been looking at all the parts of the kidney, and we've looked at the first of the three stages of urine formation, and that first stage was called what? It occurs between the glomerulus and the Bowman's capsule when substances move from the blood plasma into the Bowman's capsule. Now that substance is called filtrate. What is that process? Good. Glomerular filtration. Filtration. Why does filtration occur at the kidneys? Why does it? What is the driving force for it? It's a type of pressure. Hydrostatic pressure of the blood plasma. Okay? And it is greater than the sum of the two opposing pressures, which are glomerular osmotic pressure and capsular hydrostatic pressure. If that you don't understand that, go back and study that. That's real important test wise. Okay, and what you're seeing on this table is on the left that bar that says 180 liters. On the average, that's how much filtration occurs. That's how much filtrate is produced over a 24-hour period. All right, so that's how much fluid is moving from the blood into the Bowman's capsule. But you don't urinate nearly that much. So now what we've got to do is get it from this point down to that amount, and this is how much you urinate on the average in a 24-hour period. So obviously from this chart, it's showing you that a whole lot of things get filtered that you need to still keep. Okay, and you reabsorb those substances through a variety of transport mechanisms, but all of it together is called tubular reabsorption. So this is when substances that are now in the filtrate of the proximal convoluted tubule, distal convoluted tubule, and loop of Henle, while it's in there, things are reabsorbed into the blood of the peritubular capillaries. Most of it occurs early at the proximal convoluted tubule. I think it's interesting that in the proximal tubule, but nowhere else in the nephron, you see microvilli. Do you remember another organ that had microvilli on its cells that we've recently encountered? In the small intestine. Isn't that where most nutrient absorption occurred? And the whole purpose of those microvilli was to give it more surface area for absorption. Because more reabsorption occurs in the proximal convoluted tubule than the loop of Henle or distal tubule, it's modified with microvilli. That's pretty neat. Structure helps relate to the function. Okay, there's a lot of different kinds of transport mechanisms. And your book gives maybe a little bit more discussion of these, but you'll recall a lot of these terms: active transport, passive transport, pinocytosis, osmosis. There's a lot of ways substances are transported. What are some things you remember about active transport way back in AMP1, like chapter 4, 3 or 4, chapter 3, I think. Energy is required for active transport. And then another requirement is a protein carrier, because the substance can't transport on its own. Maybe it's not lipid soluble, so it can't transport across that hydrophobic barrier of the cell membrane. All right, and so because any substance that's actively transported has to have carrier protein specific for that substance, then that means there's going to be a limit as to how much can be transported at any given moment. And that limit is determined by how many of the carrier proteins are there. Okay, and so let's say if here's a renal tubule, and here's a peritubular capillary, and a substance has got to move across through active transport, but it can only do so if there's carrier proteins for it. And just for my purposes, let's say there's, the example I'm using is glucose. There are several things that can be actively transported, but we're just going to use glucose as the example. So these little blue dots over here represent glucose carrier proteins. And do you see on my picture I only have 5 of them? And so just for this simulation, only 5 glucoses can be transported at a time, right? So as long as you don't have over 5 glucoses right here in the filtrate, as long as you don't have over 5, then every bit of it's going to be actively transported, right? Okay. Glucose is one of the substances that, after it gets filtered, you want to reabsorb every bit of it. So you have enough protein carriers for glucose for the normal amounts of glucose that are in the blood plasma. Okay, so let's say up here, I know my drawing's pitiful, but let's say there's Bowman's capsule and filtration's going to occur. As long as the glucose levels in the blood are 5 or less, then you're going to be able to reabsorb it all, right? And so let's say the normal glucose level in the blood is 5, which is not, but just for these purposes. Okay, what if somebody has diabetes? Their glucose level is elevated. Maybe they don't produce enough insulin, so a lot of that glucose cannot move into the cells. That's what insulin does, allow glucose to move into the cells. So when they filter at the nephron, it may not be 5, it'll be 7, because their blood glucose level is higher than norm. So do you see how only 5 are going to get transported through reabsorption? And so you'll have 2 left over, and that's what shows up in the urine. And that's why one of the classic signs of diabetes is, in a urinalysis, glucose appearing in the urine. Okay? It's because it has exceeded what we call the renal plasma threshold. Okay? So anything, I've spent way too much time on this, but anything that is actively transported, there's a limit, and that limit is called the renal plasma threshold. Okay? As long as you don't have more of that substance than the number of proteins, than the threshold amount, then that substance is not going to show up in the urine. Okay? And but a lot of things do show up in the urine that are actively transported. It's just because you don't need to reabsorb every bit of it. So you're not going to have as many carriers for it. Okay. All right. Another type of transport is pinocytosis. Do you recall that that is a type of endocytosis where the cell membrane indents and then any substance can fall in that as if it's dissolved? Okay, so some examples of pinocytosis would be the small proteins are transported that way. Now, if that may bring a red flag in your mind, because I thought proteins were too big to be filtered. Okay, most of them are. Most types of proteins are, but some of the little bitty ones, like albumins, can be filtered. But you usually don't see that in the urine because they are reabsorbed through pinocytosis. Okay. Okay. And then so here you see some examples of things being transported. Okay, so let's say here's the sodium ions. They're actively transported. Okay, and then that's followed by chlorine or ions. Right, and I'm kind of getting ahead of myself on this picture. But another kind, we'll come back to this picture. Another kind of transport is passive transport. Okay, I didn't use that term with you in AP1 for passive transport, but that's just normal diffusion. Okay, it's just regular old diffusion, and it doesn't require extra energy. All right, but this is a different kind of passive transport, and it's where like a positive ion is reabsorbed through active transport, like the sodium that I've circled, and then a negatively charged ion is just going to move along with it. It's sort of like it piggybacks along with it because it's magnetically attracted, because it's an opposite ion. So that it doesn't necessarily require a carrier, it'll just follow along with it. Okay. So that would be another example, is passive transport. And then a huge type of transport that occurs at the renal tubules is osmosis. And of course that's the diffusion of water across the semi-permeable membrane. And we're going to see that in a lot more depth in just a minute. But that's just one of the transport mechanisms. Okay. And then, so in filtration, substances are moving from the blood into the tubules, right? from the glomerulus into the Bowman's capsule. In reabsorption, substances are moving from the tubules where? Into the blood of what blood vessels? The peritubular capillaries. Remember, the peritubular capillaries surround the proximal convoluted tubule and loop Henle and distal tubule. Okay, tubular secretion is just the opposite of reabsorption. That's when substances are moving from the peritubular capillaries into the tubules. Because always when filtration occurs, there's going to be some things that don't get filtered that you need to. Because filtration is just let's move it across, but not everything moves across because the blood is continually moving from the afferent arteriole to the glomerulus into the efferent arteriole. So some of the things don't get filtered that you need to get rid of. And so from the efferent arteriole, blood is moving from there into the peritubular capillaries. And so now those things you still don't need are in the peritubular capillaries, and then they move back, they move into the filtrate of the renal tubule through secretion. Okay, and there's different transport mechanisms involved in that. Active transport is used there. Again, lots in the proximal convoluted tubule, like hydrogen. This is your body's last effort to get rid of excess hydrogen. If you've got a little excess, if your blood's too acidic, if it's dropping, the pH is dropping below 7.4, that's that normal blood pH, then you can secrete excess hydrogen from the blood into the renal tubule, and it'll show up in the urine. Okay. Other ions like potassium, ammonia, NH3 is ammonia. That is a highly toxic chemical that is just a normal byproduct of some of our metabolic reactions, and you need to get rid of it. It is extremely toxic. All right, and so if you have any left over in the blood, it can be secreted. Okay, various drugs, histamine. Okay, so those can show up if they are still in the blood. They can be secreted. So that's why with drug tests, it's a urine test because these drugs can be secreted. Okay, so here we're seeing, here you see, this would be in the renal tubule. So this is the filtrate. Here's the blood of the peritubular capillaries. So this arrow, that would be referring to absorption, and this would be to secretion. Okay, so they're just opposite movements. Okay, and they're occurring all at the same time. I know we've taken these filtration, then reabsorption, then secretion, but it's all going on at the same time. Okay. And so here's just a little quick review of it. I like this picture. If you have an older book, you don't see this picture in the book. So this is brand new for this textbook, and I like it for once. I like the new picture. But anyway, this is showing what process, which of the 3 steps of urine formation. What is that one? Come on. Substances are moving from the blood of the glomerulus into the peritubular capillaries. That is referred to as glomerular filtration. Good. Okay. The blue arrow, what process is that? From the filtrate back into the blood. Reabsorption. And then the yellow arrow is secretion. Right. Okay. And so do you see how reabsorption and secretion are occurring at both the proximal and the distal convoluted tubules? Okay. All right. Okay, now, the kidneys are the major organ, the organ that actually regulates how much water is in your urine compared to all the solutes, its concentration, and then the volume of it. And there's 2 big mechanisms that control that. And this is extremely important because if you don't regulate the water content in the urine, then your body, you may get way dehydrated. If you've got too much volume in your urine, you will dehydrate very quickly. And the kidneys are extremely important in that process, not just getting rid of waste products, but also water levels of the body. Okay, and that's what this topic is about. There are 2 types of mechanisms which aid in this urine concentration and volume. One has to do with hormones, and the other is something kind of bizarre called the countercurrent mechanism. Your book might go through countercurrent first, but I like to look at the hormone action first because then it makes countercurrent make sense. Okay? All right, and so one of the hormones that helps to regulate the volume and concentration of urine is aldosterone. Do you recall that that is produced at the adrenal cortex? It's a type of steroid hormone. It's just not a sex steroid hormone, but it affects sodium levels in the body, and pretty much wherever sodium goes, water's going to follow. So that sodium levels and water levels go hand in hand. Okay, but then another hormone that is extremely important, this is the one we're going to talk about a lot, is ADH. Do you remember what ADH stands for? This is a hormone, it's one of the two hormones we talked about way back in chapter 13 in the endocrine system. This is one of the two from the posterior lobe of the pituitary. Okay, ADH stands for anti-diuretic hormone. Anti-diuretic hormone. Okay. And it's, remember the posterior lobe of the pituitary? Like if here's the anterior lobe and then here's the posterior lobe. Do you remember that there are cells from the hypothalamus that extend down into the posterior lobe? And then they release chemicals which are acting as hormones that go directly into a blood vessel. Okay, so technically they're hypothalamic hormones, but because they're released at the location of the posterior lobe, we consider them posterior lobe hormones. Okay, y'all recall that now a little bit? All right. Well, anyway, one of those hormones is ADH. And like every hormone of the body, it has specific target cells. And the target cells for ADH are at the distal convoluted tubule of a nephron, and then the collecting ducts in the kidneys. Okay, so let's see. I think I want to put a blank slide up here, and okay. So it's going to take me a minute. Let me draw a collecting duct, and then we're going to draw. There's a distal tubule that connects to it. I'm going to draw it kind of minimal. And then remember the loop of Henle. I'm going to draw the loop of Henle huge right now just because I'm going to need it in a minute. So there's a loop of Henle. And then there's proximal convoluted tubule. Oops, I want to do that different. Let's say there's the glomerulus. And then we have afferent arteriole, efferent arteriole. Afferent's bigger, recall that? And then we're going to have a Bowman's capsule around it. And then there's proximal tubule that leads to the loop of Henle. Okay, does that make sense a little bit? Okay, here's the collecting duct, and here's the distal convoluted tubule. Those are the areas that have receptors for ADH. Okay, if ADH is not present, okay, if ADH is not present, which is normal, so it's just normal. When ADH is not present, the distal convoluted tubule and the collecting duct are impermeable to water. Okay, so what that means is as the filtrate comes up, the ascending limb of the loop of Henle, by the time it gets to the distal tubule, that means regardless of how much water is there, it's not going to be reabsorbed, okay, when ADH is not present. And so we could just say it in your book, in your notes. It says this: normally, the distal convoluted tubule and the collecting duct are impermeable to water. So it doesn't matter how much water is on one side or the other; it's not going to be reabsorbed, okay? And it's not going to be secreted. It won't, because water can't move across the distal convoluted tubule or the collecting duct, okay? But sometimes your body gets dehydrated, doesn't it? And an area of your body that recognizes that is in your hypothalamus. Remember, that's your thirst center. And if the hypothalamic cells, these osmoregulatory cells, as they lose about 1% of their amount of water, do you recall that they're going to make an impulse go to your salivary glands? Saliva production slows down. You feel thirsty, so you'll drink water. Okay, at the same time that's going on, those cells send an impulse down to the posterior lobe and release ADH. And ADH comes over and binds to its target cells, which are along the distal convoluted tubule and the collecting duct. And so when ADH is present in those areas, which is when you're dehydrated, when ADH is present, the distal convoluted tubule and the collecting duct are permeable to water. Okay? They are permeable to water. So that if you need to reabsorb water, you can. Okay? It's your last ditch effort to retain water, is through the action of ADH. Does that make sense? Okay, now that's it. You're thinking, man, she has spent a long time on that. That makes sense. And if ADH is not present, distal convoluted tubule and collecting duct will not reabsorb water. If ADH is present, those two areas will reabsorb water. Okay. However, water always moves through osmosis. We don't have hydrostatic pressures here. It's not a lot of hydrostatic pressure. Everything's due to osmosis. Okay, and remember, I have gone through osmosis a gazillion times in this class, but we're going to do it again. I think it's really important. I've told y'all that before, haven't I? Let's say if this is 10% solute, we'll say our solute is salt. It doesn't matter. I can use any solute. And this is 20% solute. And this membrane that separates those two solutions is not permeable to the solute. It's not permeable to salt. But it is permeable to water, right? Okay, so we have side A and we have side B. So if I use words like hyper, hypo, or isotonic, you would say side A is blank to side B. What would you fill in the blank? Side A is hypotonic. Side A is hypotonic to side B. Side B is hypertonic to side A. The hyper and the hypo refer to the solute, not the water. Okay? Okay, and so side A has less solute than side B, therefore it's hypotonic to B. Okay? What is the net movement of my water? From A to B or B to A? Net movement of water, you got more going from A to B than B to A, because if A is 10% salt, it's 90% water. And if B is 20% salt, it's 80% water. And water always moves randomly in a net movement of high to low concentration, right? So in other words, it's going from the hypotonic to the hypertonic. Do you see how water moves toward the hypertonic solution? Okay. Let's go back to the nephron. So do you see, because of what I drew here, do you see that in order for ADH to be effective, this area needs to be hypotonic to this area? Do you see that? So that water will move when ADH is present. If the distal tubule were isotonic, so remove hypo, and let's say, remove that. Let's make it isotonic. and let's say ADH is present, yes, water can move, but you'll have just as much going out as you have going in, wouldn't you? Because it's isotonic, which is not going to help you when you've dehydrated, is it? You're going to remain the same level. Okay. So what if, heaven forbid, this were hypertonic to the outer environment? Then in ADH is present, yes, water's going to move, but water moves toward the hypertonic area. So that means your body's going to lose even more water to the filtrate, which makes you more dehydrated. So do you see how it's very important that you be hypotonic? Your filtrate is hypotonic by the time it gets to the distal tubule, so that if you need to reabsorb more water, you can through the action of ADH. So if you were to analyze the composition of the filtrate at the distal tubule, it is always hypotonic to its surroundings. It always is, whether you need to reabsorb water or not. Because if you don't need to reabsorb water, you won't release ADH. And the distal tubule and collecting duct, without ADH, they're not permeable to water. So that water will just remain in your urine, and you'll have more diluted urine. Sometimes your urine's more diluted than it is at other times, isn't it? Have you ever noticed, if you've gone a long time without drinking water, your urine is very concentrated? And that's because ADH is kicking in. So you're reabsorbing water. You don't have as much in your filtrate. And so your urine's going to be more concentrated. Okay? Have you ever heard that a person who is diabetic, a classic sign before you go to the doctor is not only extreme thirst, but excess urination? You ever heard of that? That's another classic sign of diabetes? The reason for that is because if you're diabetic and you have excess glucose in your blood, that means you're not going to reabsorb it all, right? You've exceeded the renal plasma threshold. So now you have extra solutes coming at the distal tubule than you should have, which makes it less hypotonic, right? And so let's say instead of 10% and 20% over here, it's only 5% and 25%. 15% and 18%. Yeah, it's still hypotonic, but you're not going to reabsorb as much. It's not as big a difference, right? And so when you have extra substances in your filtrate dissolved in it, that's going to mess it up a little bit. And so you won't be able to reabsorb as much as you need. Okay? This is the chapter where osmosis shows up the most for an A&P student. And it's extremely important. So do you see how at this point the solutes in the filtrate are going to affect water movement? Okay. All right. And so ADH is an extremely important hormone for kidney action. Extremely important. Okay. All right. So here you see on the left you don't have ADH. So whatever water is in there is going to keep on going and become part of the urine. And then on the right, your ADH levels are high. And so at that point, you can reabsorb water if you need to. Okay, now we're going to look at this thing called countercurrent. And that occurs in the loop of Henle. Remember, you got a descending limb, and then you got the little turn, and then the ascending limb. Okay. The descending and ascending limbs are super close together, like a little hairpin, little bobby pin. Super close together. And what happens on one side, because they're so close together, is going to affect the other side. Okay. All right. And so you stay on this page. Let's look at this picture. Have y'all noticed when you look at the various images of the loop of Henle that a lot of times the drawings show that the ascending limb is thicker than the descending? Okay. That's a way to let you realize that the ascending limb is impermeable to water. Always. even if ADH is present, because ADH doesn't have target cells at the loop of Henle. It only has target cells at the distal tubule and collecting duct. So regardless of ADH levels, water cannot be reabsorbed at the loop of Henle. Okay, it can be reabsorbed at the. Water cannot be reabsorbed at the ascending limb of the loop of Henle. It can be reabsorbed at the descending limb. Okay. All right. So going back to filtration. Remember I said whatever the composition of the plasma is, that's what the composition of the filtrate is. It just gets it across, right? All right, and so after filtration has occurred, the filtrate at the proximal convoluted tubule, when it's first forming, that filtrate is isotonic to its environment, to the blood of the its environment means blood of the peritubular capillaries. Okay, it's isotonic. But as it starts moving down, some things are going to happen to it. So let's say it moves on down, moves on down, moves on down, and it comes up the ascending limb of the loop of Henle. Okay, at this point, salt is pumped out of it. Like sodium's pumped out and chloride follows, but we just say salt moves out. So do you see how salt's pumped out of it? It's just actively transported. It's transported. Okay, and this salt stays in the interstitial areas. There's a mechanism that prevents it from going back in the blood. It just stays in the interstitial areas. So do you see how this area gets real salty? In here, it gets very salty. And remember how water is drawn to sodium? Okay, just through osmosis. And so on the side of that loop of Henle that is permeable to water, water moves out. So do you see that? So as water moves out of the descending limb, instead of being isotonic anymore, now it is hypertonic when it gets down to the bottom. That's weird, isn't it? But that's because water's moves out. Water's moved out. Water's moved out. Okay, and then as it comes up, now all this salt, any salt that's there is going to pump out, pump out, pump out. Okay, the salt doesn't circle. It doesn't cycle. It stays in here. Okay, any salt that's pumped out is what's coming from the blood. Okay, it keeps pumping, 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 pumping. So do you see how it gets saltier, 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 saltier? And so water can continue. I know I'm making a mess here. Water can continue to move out. So water moves out of the what limb? Descending. Salt moves out of the ascending limb. Okay, and as salt gets pumped out, the more of it that gets pumped out, that's what makes the fluid hypotonic by the time it gets to the distal tubule. And so that movement of opposing movements of the ascending and the descending limb, that's referred to as a countercurrent mechanism. Okay? Do you recall that you have two kinds of nephrons? Oh, what is that? You got two kinds of nephrons. You have those that sit up high in the cortex called the cortical nephrons, and those that sit low in the cortex and have super long loops of Henle down in the medulla, they're called juxtamedullary nephrons. Do you recall that I told you animals that live in a desert environment have more juxtamedullary nephrons? It helps them retain water. Okay, the longer the loop of Henle is, the more effective this countercurrent mechanism is, because it gets there's more time for it to be saltier and saltier and saltier. So the saltier it gets in between the proximal and distal tubules, the more water is going to move out. Not proximal and distal, the ascending and descending limbs. The more salty it gets there, the more water is going to move out of the descending limb, which means it's not going to be in the filtrate, so you're going to be able to retain it better. Okay? And also, because it's saltier and saltier, it makes it even more hypotonic by the time it gets to the distal tubule. And the more hypotonic it is, the more water reabsorption can occur through ADH action. Okay. Okay. So do you see why this is sometimes referred to as a countercurrent multiplier? The longer it is, it kind of pyramids. It gets bigger and bigger and bigger and bigger. But that helps it become hypotonic. So the whole purpose of this countercurrent mechanism is to create a very highly concentrated interstitial fluid which in turn makes the filtrate hypotonic by the time it comes out of the loop of Henle. Okay, and it says that in your notes right here. Okay, I think somewhere. Next slide. The whole purpose of it. Okay. All right, on that second bullet, you see that's the purpose of it, so that ADH can be effective if it needs to be. Okay. For a lot of students, this is the trickiest part of the kidney. It's this countercurrent mechanism. But for your test, you just need to know what the tonicity of the fluid is at the various points. It starts off at the Bowman's capsule, it's isotonic. And then when it gets down to the bottom of the loop of Henle, it's hypertonic because it's losing water, right? And then by the time it gets up to the distal tubule, it's hypotonic because it's losing a lot of salt. Okay, know that. And then know that with the countercurrent mechanism, water moves out of what limb and salt moves out of what limb. Okay? All right. Now, there are other countercurrent mechanisms in the kidneys. The one I just went over with you is the only one I'm going to test you on. Okay? But there's another one that prevents all that salt from getting into the blood. It stays in the kidneys. I would guess if you were in England and you were eating kidney pie, it might be kind of salty. Y'all ever heard of kidney pie? Yeah, I would think kidneys are kind of salty because of this. You know. But I don't know. I don't know. I've never had kidney pie, and I never desire to. But there's another countercurrent mechanism that affects urea and uric acid. Both of those are some nitrogenous waste products from protein and nucleic acid breakdown, and you need to get rid of the bulk of that. And there's countercurrent mechanisms that get that into the filtrate from the blood. But sometimes you have a lot of those, and if your urine is not very diluted, you know, if it doesn't have as much water in it, and or if it has a lot of solutes, especially uric acid, some of those solutes can come out of solution. Uric acid is not very soluble compared to urea. Urea typically doesn't come out of solution. It's fairly soluble. But uric acid's not soluble. So you need to have a lot of water in order to dissolve it. But if you lose some of the water or you have excess uric acid, it'll come out of solution. If it does that in your tissues, that's called gout. You may have heard of that. But it can also cause kidney stones. Kidney stones a lot of times are caused by excess calcium that comes out of solution. You know, maybe calcitonin levels are out of whack, or your parathyroid hormone levels are out of whack because they're affecting calcium levels in the blood. But that could form kidney stones also. A kidney stone is called a renal calculus. Okay. Some people think of the course calculus as a kidney stone. Anybody ever had calculus? It's tough. You're supposed to laugh at that. But it's too early today, isn't it? Okay. This is a countercurrent mechanism that is keeping all that salt from too much of it from getting into the bloodstream. Way back when we first started the kidney and we were talking about the blood flow, and I mentioned peritubular capillaries, and I mentioned an extension of peritubular capillaries. It's called the vasa recta. You won't see that term on your test, but they're involved with some of this countercurrent. But it's part of the peritubular capillaries. Okay. All right. So when it's all said and done, you filtered, you reabsorbed, and you've secreted. Now you have urine. Okay. If you've ever wondered what's in it, it's mostly water. And of course, the water content varies just depending on your body that day. Varies mostly with how much you drank that day. But it also contains some nitrogenous waste products like urea, uric acid, creatinine. Most of our urea comes from amino acid breakdown. Uric acid comes from nucleic acid breakdown, and creatinine comes from creatine phosphate breakdown. You may have some trace amounts of amino acids, but what you typically, and then you're going to have various electrolytes that you had in excess in your blood that you can get rid of. And what you don't see under normal conditions is glucose, because you have enough active transport carrier proteins for glucose. And what you typically don't see is protein, because any proteins, little proteins that got filtered, are reabsorbed through pinocytosis. If you see protein in the urine, that's an indication of either you just ate super high protein meal. You know, a lot of people now are on these real high protein diets. They're not always thinking that's a real good thing for your kidneys to have that elevated proteins. But anyway, another in a medical sense, if there's protein in the urine, that could be an indication of a kidney infection. If somebody has a kidney infection, their glomeruli are too porous, and so proteins are moving across that wouldn't normally, and those bigger proteins typically can't be reabsorbed like the little tiny ones. Okay. All right. Now, medically, a renal clearance test helps determine the filtering rate at the kidney, which is an indication of kidney efficiency. And what they'll do they want to figure out, okay, you know, if it looks like you've got some kidney issues, they'll probably run you through a renal clearance test. And what they do is put a substance that gets in your blood. So because it's in your blood, it makes its way to the kidneys, and it's filtered along with everything else at the kidneys, but neither is it reabsorbed nor secreted. Okay, so it just kind of is inert. It just sort of runs through. And so they look at the point of it getting in your body to the point of when it shows up in the urine, and that's an indication of kidney action. Huh? It's crazy. Yeah, but that's what they do. But the common one that's used, I think, is the inulin clearance test. You don't have to name them, but it's just a test that indicates glomerular filtration rates, which tells you, in essence, the efficiency of the kidneys. All right, so we have spent a lot of time on just the kidneys, but we also have the rest of the urinary system. And once filtration, reabsorption, and secretion has occurred, now it's in the collecting duct, where you may have some water reabsorption if ADH is present, but that's about it. But that goes then, the urine, now it's called urine, and it passes through a renal papilla into the minor calyx, major calyx, and the rest of the pelvis. Remember, all of that pelvis, major, and minor calyx is part of the upper part of the ureter that's within the renal sinus. Okay, and then from there it gets into the rest of the ureter, to the bladder, and then out the urethra. So what we're going to do now is look at the ureter, the bladder, and the urethra. Nothing really happens there. It's just peristalsis occurs to move the urine through the ureter. But it also is positioned retroperitoneally. What does that mean? Retroperitoneal. Behind the parietal peritoneum. And then it connects to the bladder. But it's interesting, it doesn't join to the top of the bladder. It kind of comes behind the bladder and joins from the underside. Okay, we'll see that on a picture in a minute. It's lined with the mucus coat, and urine doesn't pass through it because of gravity. It's like the esophagus. It's squeezed through peristalsis. Remember, peristalsis is a wave of smooth muscle contraction. If there's an obstruction in a ureter, like a kidney stone, all right, so just imagine, here's a ureter. If there's a stone in it, do you see how that backs, the urine can't go anywhere, and ultimately it backs it all the way up to a Bowman's capsule, or the million of Bowman's capsules. And so do you see how that's going to up the capsular hydrostatic pressure, which could then override filtration? Couldn't it? And it can make it backfire. Everything would move back into the glomerulus, which would be horrible. And so your body has a mechanism that helps prevent that. And it's hard to say, it's called the ureterorenal reflex. Ureterorenal reflex. And what that is it's a combination of two things. It's a slowing down of filtration at the affected kidney, and then it's an increase in peristalsis of that ureter. And so it's trying to move it through. If you've ever had a kidney stone, I've never had one. People who've had them say they're just unbelievably painful. But they're feeling that pressure during that peristaltic movement, trying to push it through. Because there shouldn't be any solid there. It should be just liquid. Okay, so that's the ureterorenal reflex. Okay. All right, so there you see the ureter. And then here, if you look at a cross section, what's not in your notes is the type of epithelium that lines it. And the bulk of it is transitional epithelium. That's that weird kind of, it's a stratified epithelium, kind of like stratified squamous, but all the cells aren't flat at the top. And it changes from 2 or 3 layers to maybe 8 or 10 layers. You know, it's not as thick as stratified squamous. So it has that function of distensibility, but you see some of that there, and that's what you're seeing lining it, is some of that transitional. Okay. All right, in the bladder, that's the next organ. It's located underneath the parietal peritoneum. So that's kind of weird, isn't it? Your abdominopelvic cavity, you know, a lot of times we just call the whole thing abdominal cavity, but there's actually, if you think about the parietal peritoneum that lines the abdominal cavity, it comes around at the bottom of the abdominal cavity, and then below that is the bladder and internal reproductive organs. So that would be within the pelvic cavity. Okay, so the bladder is under that parietal peritoneum. In females, of course, its location is just in front of the vagina and uterus. The trigone, let's look at a picture of it just a minute and we'll see. It also has a mucus coat lined with transitional epithelium. And then the muscle in its wall is in little bundles. It's not super thick like in the uterus or the stomach, but it's called the detrusor muscle. And that's the reason you got to have transitional epithelium, because it can't stretch as much because of the muscle, so the epithelium can stretch or distend. Okay, and then the outer part of it is a serous layer, and that's just at the upper. That would be that parietal peritoneum coming across. That's kind of weird. But I'll come back to urethra. Let's look at a picture here. Okay, here you're seeing a bladder, and there would be a ureter. There's a ureter, and where the ureter penetrates it is right here. So it's on the back side coming in, and then anteriorly is an opening that leads to the next organ, the urethra. So that's in male and female. You have that. And so that there's a triangular area at the floor of the bladder called the trigone. Okay. And then the detrusor muscle is all this in the wall. And then right there, that lining would be the transitional epithelium. Okay. Okay. All right. And so I'm just going to go on and talk about the urethra. So you can look at the slide. I believe it's a slide before this one and see the notes. Okay. Let's do female first. Of course, in females, the urethra is strictly a urinary organ, whereas in males, it's urinary and reproductive. Those two systems join. But in females, it's totally urinary. All right, and here's the urethra, okay, and that just transports the urine to the outside of the body. But there are some sphincter muscles that control whether the urine's going to move out or not. And one of those is smooth muscle. That's the internal sphincter, this smooth muscle. Notice that it surrounds the internal urethral orifice. Okay, so you've got 2 openings at either end of one at either end of the urethra. This is the internal opening. There's the external opening. The opening is called an orifice. Okay, and the internal urethral sphincter is surrounding the internal orifice. That makes sense, and it's smooth muscle. The external sphincter in females is skeletal muscle, and it surrounds the external opening. That makes sense. And both of those have to relax when urination occurs. In males, though, if you look at the urethra, there's three parts. There's one part, there's one part, and there's one part. Okay, and so the blue, that would be called the prostatic. So prostatic urethra. Okay, and it is called prostatic because it's inside a reproductive organ in males called a prostate. Don't call it prostrate. Prostate gland. Some people say prostrate. That's wrong. Prostate gland. We'll see that in the next unit and we'll see its function. But the prostatic urethra passes through that. The membranous urethra is the shortest part in males, and that's this green area. And membranous urethra, and that is where that's where the external sphincter is. So the external sphincter in males is not at the distal end of the urethra. It surrounds the membranous urethra. Okay, and then the last part of the urethra runs through the penis, so that's the penile urethra. Okay, and then the orifice, of course, is at the end of that. But we'll see all of this again when we do reproductive system, because in males, the urethra is urinary and reproductive. Okay. Some men struggle with prostate issues, either an infected prostate, like a bacterial infection, or an enlarged prostate. You know, most men, as they get older, the prostate enlarges. And some of the symptoms of an enlarged prostate would be more of an urge to urinate. And that's because if the prostate enlarges, it pushes up against the bladder, and there's more of an urge to urinate. But when the man tries to urinate, not as much urine can come out, so he feels like he can't empty his bladder completely. And that's because when the prostate is enlarged, it presses against the urethra, so we can't dilate as well. And anyway, it can be, very irritating to men. But okay, let me make sure I got all that. Okay. All right, and then here's a sectioned view. We'll see this again when we do the reproductive systems, but just to get your bearings on the sagittal section, in females, this is urinary, this is reproductive, this is digestive. So there's three separate tracts, okay, externally. All right, in males, there's digestive, here's urinary, and then here's reproductive. See how it connects to the urinary, okay? And so there's just two openings. Right. Some animals, did you know some vertebrates just have one opening? And digestive waste, urinary waste, and reproductive fluids go through that same, empty into that same area. It's called a cloaca. And reptiles have it. Birds have it. You ever notice birds have one opening? All right, and that's where all three systems converge. It's interesting. All right. Urination itself, you might have thought urination was a scientific word. The actual word is micturition. And before you're born, it involves a reflex, the micturition reflex. Not before you're born, excuse me. Up until you reach the age of being potty trained, it is a reflex. Okay? And the micturition reflex center is located in the lower part of the spinal cord. Okay, remember, it's just simply a reflex. If the bladder fills up enough with urine, it stretches, stretch receptors get activated, and a sensory impulse is sent to the reflex center in the lower part of the spinal cord, and that connects ultimately with a motor neuron that then sends an impulse out to the detrusor muscle to make it contract. That's the detrusor muscles in the wall of the bladder, and then it causes the two sphincter muscles to relax. Okay? And even the skeletal sphincter. At that point, early in your life, you don't have conscious control over that skeletal sphincter. Okay? And then, so urination will occur. When you hit about age 2 or 3, your nervous system, has developed enough to send inhibitory signals down to the reflex center to stop the continuation of the reflex on the motor neuron. And at that point, you have conscious control over urination. But many of you one day might be dealing with patients who are paralyzed, or elderly patients. Their nervous system doesn't work quite as well. They don't have as much conscious control. And so they'll have urination when they don't want to. But like if you had a spinal injury, that injury severs the connection between the brain and the reflex center. And so you lose that ability to control it. All right, we'll look at this quick little video, I think.
The micturition reflex involves impulses traveling from the urinary bladder to the sacral region of the spinal cord and from the sacral region of the spinal cord back to the bladder. It is coordinated by neurons in the spinal cord and can be influenced by signals from the brain. When the urinary bladder becomes stretched, there is an increase in the frequency of action potentials carried from the bladder wall to the sacral region of the spinal cord. In response, parasympathetic neurons from the spinal cord to the bladder are activated, and this causes the smooth muscle on the bladder wall to contract. The sensory signals to the sacral region of the spinal cord also stimulate ascending pathways to the pons and cerebrum, which results in a conscious desire to urinate. If urination is not convenient at the time, the brain sends impulses down the spinal cord to inhibit the micturition reflex. Impulses carried via somatic motor neurons keep the external urinary sphincter contracted, which also prevents urination. When urination is desired, signals from the brain stimulate the micturition reflex. The brain also decreases action potentials in the somatic motor neurons to relax the external urinary sphincter.
All right. We'll take a break, and when we get back from our break, we'll go through the next chapter.